And we can go ahead and get started. Well, good afternoon and welcome to our July action period call for the preventative health program. You have some new faces here on the program. Alex, who you're used to hearing and seeing every month, as you know, has moved on to DC with her fiance. So myself, Elizabeth Dawson, and we have Kristen Flewitt and Haley Southworth. Our staff will do our very best to carry the torch for her and finish out this program. And if you need anything throughout the action period call or throughout the rest of the life of the program, please let us know. We're happy to help you with anything that you may need. So for the agenda today, we're doing our good morning and our welcome. Welcome to Dr. Bowling as well, the medical director. We have maternal health, screening for maternal health at the WellCare visit with our guest speaker, Dr. Lazaron. We'll have a data overview. And then we'll have a chance to hear from you all, kind of successes and wins and discussions and questions that you might have. Dr. Bowling is going to facilitate a chapter report go around, and then we'll end with some wrap up and some reminders as we move toward the final quarter of this program. A couple reminders at the start. So data, again, will be due, your last data will be due August 18th. So if you continue your submission process for that per usual, Haley will be taking a look at that data and putting it into chart format and reporting it out to you, as well as your PDSA cycle results, which are due September 21st. If you have missed an action period call, they are all cataloged in your project folder, so please access those there. And then I think that's all for updates and reminders. So I'm going to go ahead and turn it over to Dr. Lazaron to give us an update on screening.
Okay, well, thank you very much. I'm really happy to be talking about this topic to a group of pediatricians. Full disclosure, I am not a pediatrician. I just aspire to be one, and I like hanging with the group of people who are focused on the well-being of children and their families. The thing we're going to be talking about is screening for maternal depression at the Well Child Check, and I want this to be as easy as possible without hanging you up and absolutely killing your schedule. I also have to say that it's ironic that I'm giving this topic because I was voted during my third-year clinical rotations in medical school as the person least likely to become a psychiatrist of anybody in my class. So here is the take on maternal depression screening from someone who is very concrete and action forward, which I hope will help to let you conceptualize how to use the screening within your space. Next slide. We're going to talk about just kind of three key topics. Why are we screening caregivers at a well child visit? How can I screen and intervene effectively without adding a substantial amount of time to the well child check? And how to get paid for the work you're doing. And that's a big part of what makes this sustainable in the long run. So I'm hope to be able to hit a little bit on each of those topics. Next slide. The reason why we're so interested in this is maternal depression screening affects the well-being of all the infants that we're seeing. We have good data that says that children who are exposed to maternal depression before the age of 1 have some really significant physical, social, cognitive risks. The moms are much more likely to stop breastfeeding, restart smoking, so there's secondhand smoke exposure. They're less likely to keep up with things like well child visits and immunizations. They use the emergency room rather than their primary care doctor. And this is common enough that 1 in 8 women report symptoms of depression after giving birth. This is not an insignificant number of our population. Next slide. Now, this has carryover for later childhood as well, when they looked at downstream consequences of children who've been affected by maternal depression. The prenatal consequences, we know, poor prenatal care, higher preterm birth rate, lower birth weight, less likely to get the proper nutrition. The infant we've just talked about, but there's also a lot of behavioral stuff that comes into play here. There's a lot of passivity, withdrawal, and then it just dysregulated attention and arousal. And Infants show lower cognitive performance, which is something that continues on through toddler, school age, and adolescence. Whether that gets ameliorated if a mother then gets treated, there's some evidence to say that that does. But an untreated mom with depression that continues without being able to address that issue will continue to have long-term downstream consequences for the child that'll extend all the way out to the point where they're an adolescent, where suddenly you find that the child has increased risk of ADHD, conduct disorder, learning disorder, anxiety disorder. A lot of this having to do with learned behaviors as well as the adverse childhood experience of that consequence of being a child born or a child living with a parent with coping with depression. Next slide. So now, and it's not just infancy that we noticed it. We definitely start to see young children responding to parental depression. Sleep disturbance is probably one of the very first things we see. A kid who cannot auto-regulate has that heightened arousal and will not, if they wake up in the middle of the night, can't settle themselves back down to sleep, as they're just checking to make sure, is the world safe? Children have, in a parent who may have been doing well, but then develops depression at the age of 12 months of the infant's life, the children may regress to an earlier stage when they felt safer. At 6 months, I felt safer. Let me stop walking. Behavioral changes happen too. They're passive and quiet, but also very easily alarmed. Anything can be a trigger. And you start to see more hypervigilance, aggressive outburst, that exaggerated startle, which may be related to kind of a low nurturing environment. The child learns very quickly that they need to have an exaggerated response to stress to get the care they need. And this is dose dependent. So you start to see that cumulative effect of that toxic stress leads to ongoing issues with adverse childhood experiences that correlate with higher health risk, even leading into adulthood for these young children. So next slide. So I hope I've convinced you that this is an important issue for the children we treat. But why are we responsible for taking care of the moms? We do so much for these kids already. And, honestly, the mom is not my patient most of the time, unless they're a teenage mom. But major depression disorder peaks at 6 weeks postpartum. We're talking the major depression disorder, the I can't get out of bed, I'm crying all the time, I really can't function, I don't feel like I can connect with my child. But then there's some other really recognized peaks of dysthymia, maybe a more minor mood disorder that happens at 2 to 3 months, again at 6 months, and you would think you're in the clear. The kid is 12 months, you should be out of this. There's another peak that happens then, right about the time that child learns to walk, they're suddenly into everything, and the first word they say is not mama, but no. There is another big peak of dysthymia happening with caregiving parents. And man, you would like that primary care physician for that mom to get the care they need. But honestly, moms up until just recently in Ohio got one follow-up postpartum visit at 6 weeks. Better get it in by 6 weeks because your insurance died. And a third of them did not even make this appointment. Now, there has been a change in Ohio, the Ohio Department of Health, which now allows for postpartum care up through 12 months of life. But that's a relatively new event that happened in the last year in response to the pandemic. And still, families are not used to the idea of I can continue to follow with the doctor who delivered my baby to get the postpartum 4th trimester care I need. Just isn't in the thinking paradigm of either our health system or of families. And the honest truth is, women often stop getting their own medical care for the first 18 to 24 months after a child's born until they're pregnant again and they have to seek care. Next slide. And the reason, why is it that they're not getting care? Well, as we mentioned, 35% don't even do their postpartum visit. But when you think about those people who are following up with all their well child visits, they're getting their postpartum care because they're in our offices so often. If they follow just the normal pediatrician guidelines for screening, they're there at newborn, 1 month, 2 months, 4 months, 6 months, 9 months, 12, 15, 18, 24 months. And that's not even counting the 6 to 8 illness visits that can happen during that time for well check, for weight checks, or for acute illness visits that happen. So they're just in our office all the time. We are the place where they get care, and we're the people they connect with. Now, good studies have found that you can make a difference by repeating the screening, not just in that initial newborn 6-week stage, but at 1 month, at 6 months, and at 12 months. Doing the screening at that time picked up 13% more moms with high-risk depression than if you stop this once this newborn has become an infant. So next slide. Now, how to operationalize this in your setting? It's pretty easy. There's screening and then there's assessment. Screening is 2 questions. At the well child visit, you can screen the parent for depression by using the PHQ-2. It's your quick first step approach. In the last 2 weeks, how often have you been bothered by the following: little interest or pleasure in doing things, or feeling down, depressed, or hopeless? If you score negative on that, you're done. You've screened. You can go on. If the screen is positive, though, you want to perform an assessment. And remember, the assessment is what you can bill for. And you can either use a PHQ-2 or an Edinburgh. Now, people ask, why do I want to use one versus the other? In Edinburgh, a PHQ-9 asks some questions, and you can use it for any caregiver at any time. But it has a couple questions in it that are likely to trigger off a positive on any postpartum woman. Includes questions like, have there been recent weight loss? Well, gosh, I hope so. I hope I lost that 35 pounds of pregnancy weight. Or how is your sleep been disturbed lately? Yes, I have a small infant. So those 2 screening questions will always be positive, and those are not in the Edinburgh. So if you're looking to use your PHQ-9 for any caregiver, grandma is now has custody of this infant, and you want to screen them for depression, use the PHQ-9. But in Edinburgh may be most useful as a true screen in that first 6 months of life. So, and do you have to do that yourself? No, you don't. Next slide. Get help from your team at the well child visit. You can screen the parent for depression, but have your MA do this. This should be part of, think of this as a potential for being part of the normal rooming process. You get the infant's weight, you get their length, you have your MA ask how frequently they're eating, what their stooling is like, and then you turn and you ask the parent the PHQ-2. And if it's positive, then empower the people that you work with to go ahead and give them the assessment form right then and there. So then you walk in the room, you can look at it and decide what you need to do. And remember, PHQ-9 can be used any visit, any caregiver. And Edinburgh is used best for assessing the birth mom 0 to 6 months. So why are we screening for this? What are we going to do with it? I am not a psychiatrist. How can I help with this? Next slide. You got to screen this positive depression. What the heck am I going to do now? What you need to know is that even brief interventions are effective. Let them know one simple sentence that you're there to help and that their health is also important to you. You might want to ask if it's okay if you check in with them at the next visit. Offer resources they can walk out the door with. It's not that you have to treat the depression, but you should know where you can give them a referral back to a primary care physician that they'll actually see, or a resource within the community that can give them the support that they need. And I had one practice who was on this call say they also had a great idea, which is a week or so after the child's visit, if they've given a resource, they have one of their staff call and say, hey, did you make a connection with your primary care physician or the counselor we gave you to? How's that going? Do you need any help with that? So that one simple step of that phone call later really increased the likelihood that the family felt like they could make the connections they need in the community and that they had the support from their pediatrician to be able to do well with this. So next slide. So one of the key things you can do before you even screen for depression, though, is be prepared. Know your community referral resources. We only screen for something because we know we can help. We don't screen for things that we have no hope of ever being able to help with. So know your resources first. Maybe it's a sheet that you're going to hand them. It might be the RAC card that we're using as part of this project. It may be an embedded resource if you're in a setting where you've got the help of community resources or mental health referral resources within your setting. But be prepared with that, something that's specific to your setting that's going to work well for you. And that's something when your assessment is positive, that you know that you can feel comfortable giving them as a good support. It's not a one and done, though. You have an ongoing relationship with this family. So there's a couple of things that are fairly easy, simple things you can do that make you look like a pro, that you can do within the child's medical record that helps remind you about the risks this child and family faces. So you can add there's a couple of codes you can use, like the P0089, which you can add to the problem list for children for newborn affected by maternal depression. Or if you want to use it on an older child, the C62.9, which is History of Adverse Childhood Experiences. You can use that for any ACE, but maternal depression or caregiver depression is definitely one that qualifies for this. And you could use that then for, like, say, that grandma who's the primary provider. For those people who have reminders in their system, so I know I can set a reminder right as when I'm doing the follow-up saying, I want this chart to come back to me in 2 weeks so I can remember to call that mom or make sure that the lead screen's been done or whatever. Use your reminder system to help you remember to screen at subsequent visits. Or those people who have the virtual sticky notes that you can add to your electronic medical record that reminds you to ask just how are they doing at future visits. Just that one question makes families feel like they're seen, they're heard, and that you felt that it was important for them to get the help that they need. They're much more likely to get that as well too, because of the empowerment that you have provided. Next slide. Now you're doing all this work. The only way you're going to be able to sustain this in the future outside this project is if this is meaningful for families, but also if it's not too much of a burden for your practice. So remember that you can code for this and you can get paid. If the child is the patient at the well child visit, if you use the PHQ-9 or an Edinburgh, either one, to assess the parent for depression, use the CPT code 96161, which is administration of a caregiver-focused health risk assessment for the benefit of the patient. So I suppose if you were a geriatrician, you could also use this to assess the well-being of that child who comes in caring for an elderly adult too. I think it works both ways at all ends of the spectrum of care. And you can either then with the ICD-10 code of encounter for screening for depression or encounter for screening for maternal depression, either one of these will fly and you will get paid. In the state of Ohio, you're going to get paid up through 12 months of the infant's life. And longer if you're using it just for encounter for screening for depression. Now, how do you do this and make this sustainable in the future? Next slide. By making this standard work. So it isn't just something that you have to think of and recreate the wheel each time. To add value to your practice beyond the limit of this project, think about this, how you would use this in a standalone event as well as a standardized practice. In a standalone event, it might be a child you're seeing for follow-up after a complicated hospitalization, and you notice the child is there, the child's well cared for, but the parent looks like they haven't slept in a week and are obviously wearing clothes that haven't been washed in 3 days, and have forgotten the diaper bag and obviously are discombobulated. Sometimes that's a one-off, but sometimes it's a sign of other stress. So in those standalone events that aren't the well child check, build just a documentation smart phrase that incorporates the diagnosis and the billing. So you can say, I screened by a PHQ-9 at this visit for parental depression. And anytime your MAs come out with kind of that red flag, it's like, oh, I put them in the room, but man, this mom is just seems like she's struggling. Empower them to go ahead and start that the PHQ2 anytime that they feel like their red flags are coming off. They don't have to stop and ask you first. This can be part of any assessment by any caregiver in your practice with your supervision. Now, as a standard practice, it's a well child check. Yeah, it's easy. Just go ahead and add the screening tool to your standard well child note template. And for those of you who use smart sets or preference lists for your billing, just add those billing and diagnosis codes right away into your ordering smart set. If you're lucky enough to have a support staff who places charges in for you, and then all you have to do is co-sign them, my dream. But if those of you who are lucky enough to have that, empower them to know that we're doing this. You can put the charge in, I will co-sign it afterwards, and to make that happen for you too. So this is something, those little added value things that mean that you can document it, but you also can get paid for it, and you can follow up on it in the future. So when you see a child back at 4 months, you may say, oh, I screened for this at 2 months and they screened positive. Let me see how they're doing. I'm going to screen again. So next slide. And why do we want to make this standard work? In the billing, the 2021 billing changes that happened under fee-for-service billing, incorporating risk-based medical decision-making allows you an additional avenue to bill for the work you do, as long as you document the work. So if you put in a code of adverse child experiences, or also just child affected by maternal depression, and also within your note say this visit was longer because it wasn't just the child's asthma visit, but it was also a visit where we talked about maternal depression. And so you need to bill it as a 99214 instead of a 99213 because you made some additional referrals. It's going to stand up. You're going to get paid for that. And those people who are doing value-based contracting, being able to demonstrate consistent screening, referral, or treatment for some elements of social determinants of health is also the basis for added payments to the medical home. For those of you who are doing that value-based contracting, which I think will be more the norm than the exception in the future, you're going to be at the head of the game because you can do this. Now, I promised I would not talk too long, allow some time for questions. So I do, that last slide just has some reference guides. There are those of people who are really interested and want to prove to their billers that you really can bill for this stuff. Here's the E&M coding information, as well as the social determinants of health coding. So, and I'll stop and wait for questions.
Good morning. If everyone, if you could just mute if you're not muted, that would be great. And if you'd like to unmute, ask a question, or put it in the chat box, that would be wonderful.
Hi, this is Dr. Obeto. I have a quick question. So I know you said you could get paid for billing, but one of my colleagues told me you can get paid, but you don't get any work RVUs for the maternal depression screen.
Oh, well, they bring that up with your system, because in my system, I definitely get work RVUs for adding any screening test I do. So if I add it, that is a system-based thing, and you should say, I did this work, I should get paid for it.
Okay. Because I know the practice gets the RVUs, but the physician doesn't.
Yes, and you need to bring that up and say, this was considerable cognitive work on my part that I did, and I need to do it. Now, if they want to pull out an RVU for something that you supplied in the office, like a vaccine, but do want to pay you for doing the
counseling
administration of the vaccine and the talking about it, that's fine. So if they don't want to pay you for a supply that you gave, that's fine. But on something that's a cognitive work, you should really argue to say, I put in this work and it was part of the visit, and I need to be compensated for it. And you'd have a strong argument for that.
Yeah, because I know my colleague stopped doing them. She was like, you know what? Now If I'm not getting paid, what's the point?
You know, in
Right.
those people where they're just even being paid a flat salary, no matter what they do, know that, especially in a low resource setting, if you work in an FQHC, this is the thing that keeps the light bulbs on. You know, about half of the work I do is in very low resource settings, and all the nickels and dimes we find help. So it is maybe like counting paper clips, but those paper clips do add up, and it means that we can turn around and provide more services to the infants in our care. But definitely, if you're being paid on an RVU basis, you need to advocate to say this is not right. Since I'm sure that they're not telling surgeons that they're not going to pay them for the procedures they do just for their office visits. This was a procedure that you have performed, and you should be paid just like a surgeon is paid for a procedure.
Okay. Thank you.
You're welcome.
Are there any more questions for Dr. Lazaron? Okay, well, that was tremendously beneficial. I thank you for your time. It's always great to hear your expertise and perspective, and I'm sure we'll see you on another call very soon.
Okay, I'm going to be signing off because, like I said, I spend a lot of time in free clinics and FQHCs, and I'm supposed to be precepting 3 residents who have all just arrived just now.
Could I ask a quick question?
Yeah, sure.
With the PHQ2, when you do the PHQ2 and it's normal, can you bill for that, or can you only bill for the PHQ9?
No, it's only the 9. So the 2, which is just the screen, is just like no different than doing your vitals. But the PHQ9 you can bill for separately. Now, the fact that you have screened by a PHQ2 does allow, say that you can use that in value-based credentialing or value-based contracting to say, I am screening for social determinants of health, even if the screen is negative. But you can't like assign then a CPT code for just the screen, only for the assessment. Okay,
thank you.
Thank you so much, Betsy. That was great.
Hey, I know how to get paid for the work I do, so, and also how to do it seamlessly. So I am happy to share that expertise with you anytime. Just don't ask me how to treat the depression, because like I said, I am all the concrete.
Great, thank you.
You're welcome.
Turn this over to Haley Southworth. She's a program manager in our office, actually works with Dr. Lazaron on some projects as well. So I will turn it over to her for a data review.
Thanks so much, Liz. Thank you everyone for all of your attention and time today. Great to see your teams here. So on the next few slides, we are going to look at your data. It'll look pretty similar to what Alex has been sharing with you. I did split it up into different slides just so you can hopefully see the numbers at the bottom. As you've had some more months, we've popped those percentages in there. So on the next slide, you will see the overview for all of the topics. This is every screening and practice combined for eligible patients. So you can see how that's been going from your baseline. You've seen a substantial increase in the first month and the second month as well. That's really normal in these QI projects to see a quick jump. And then we're working on the really hard part, which is sustaining and building something that lasts long term. So across all of the topics and your aggregate for the project, your most recent months, month 5 has been 89%. Month 6 is a little drop of 79%. And part of that is related to one specific topic, which we'll get to in a moment, where there's a chance for some potential improvement. Overall, this has obviously been a great improvement in the amount of patients screened, and you've all done a great job of sustaining those. So we'll continue to add more data. 1 more month's worth of data will go in here, and we'd love to see a strong finish so you can all continue your screenings, and we'll try to support that as you wrap up. On the next slide, we're going to see the oral health area. This is actually the area where there was a bit of a drop in month 6. And to sort of explain that a little bit is that we only have 3 practices that have their data for oral health in. We have a few more that are hoping to submit their data in the next couple of days or week, and we'll update as we see that. So for oral health, the most recent month took a little bit of a drop down to 60%. That could be largely due to, again, we've got some practices that are strong performers that might need to go ahead and submit their data, but we're still significantly higher than the baseline number, which was about 5%. The peak was in the 5th month of data from all of the practices, which reached about 95%. Our hope would be with more coming in for month 6 and for that last month of data that we will see an increase back up to some of those higher areas. A lot of times a good screening goal is around 80–90%. We know 100 is challenging because you're going to have patients that come in and it's just so much else happening. So the oral health area is the one with the greatest opportunity for improvement in the most recent data shown. But on the next slide, we'll take a look at developmental screening. And this is one area that actually trended upward in a really strong way during the most recent month of data. As a reminder, we don't show you actual months here because some practices started with different months of the project. So we're trying to give you an even comparison across practices for those who have done this for, say, 4 months or 5 months, regardless of whether month 4 was June or July. So a note here is that for month 5, we have 4 practices reporting. So this month 5 number will be impacted once we get an additional month from others who are in developmental screening as one of their focus areas. But again, just like the other charts, this has trended upward and maintained pretty nicely. Those month 3 and 4 numbers of 79–77% are still very strong. So even though we went upward, if we can maintain that, it'll be great. The next topic is social determinants of health. I put a bullet here to note that we do have one practice, and we have multiple practices in this project area doing social determinant screening. One has a significantly higher portion or volume of patients than others. So this data is driven on an aggregate level a lot by that one site, but it looks great. I actually need to go in and take 120% off of the chart because you're close to 100 and I'd love to push you further, but we can't. So we'll update that. But the most recent months have all been above 90%. So really strong, great job on social determinants of health screening. The final data slide is for adolescent depression. This is another area that took a really nice upward trend, and we're again just trying to maintain and sustain this. Same as I noted on back when we looked at developmental screening, this is a project area where we're comparing your months, trying to be equal across how long you've been doing it. So there's only 3 practices reported in month 5. You'll see that number adjust on the next upcoming charts. But we've kind of seen a really similar trajectory to many of the others. Once all the data is in, maintaining those screenings between 80 and 90% is a great goal. The most recent month 5 data for the practices that are in is just above 90%. Those are some really great sustainable gains. And we're looking forward to continuing to add in that last bit of data. And I'm hoping maybe next month, as we're wrapping up and getting all of that data in, to also show you some additional pieces and dive into any of those areas that we can give you to help sustain and figure out areas that will last for a long time in your project. So keep a lookout, as Liz mentioned earlier, for reminders when data is due. The next data is due just less than a month from now in mid-August. So we'll send you an update to make sure that's in. Feel free to submit if you have June or July data in the meantime, send it in anytime. And you can shoot me a message and I'll try to make sure we update that as it goes. And I'll be sending out your charts in the next few days. I'll pop my email in the chat. And if you do have any questions, you can also put those in chat during the call too. I think that's everything I have. I'll turn it back over to our team to keep us moving forward.
Thank you, Haley. That was a great update. Dr. Bowling, our medical director, he is going to facilitate the practice report out, and then I will end with some reminders and we'll go from there.
Great. Thank you, Elizabeth. And thanks, Haley. That was some really good data coming in there. And again, I would echo, it's interesting. The data when we're compiling it all can look a little odd because of just the numbers, the ends that we're dealing with from certain practices. So overall, the message, as Haley mentioned, is good results across the board. Some things that maybe we can figure out the importance of getting your data in, but we're all kind of looking at this going like, okay, yeah, this is a really good trend. And again, we're not getting too awfully granular on each one of those though. But those of you who are doing the oral health project, if you can get your data in, that'll make us look even better. We appreciate it. So what we'd like to do is do our usual round robin and just see if anybody's got anything to report out, especially if there are difficulties or challenges or good learnings that you've had from this. So let's start off. Dr. Kumar, are you on the call by chance? I think I saw you on there. Dr. Obedo from Nationwide?
Nothing to report. Everything's been going well. Let me see. I know some of the time with the oral health and the fluoride vanish, we're trying to get the residents involved. Yep. And sometimes if it's a nurse practitioner who's working when I'm out and she sees the patients, then she might not get the oral health assessment done. But we're trying to get everybody on board now. So we're actually in the process of holding like teaching lectures so that we can get other people on board. So it doesn't matter who is seeing the patient gets the oral health assessment and the fluoride vanish if they need it.
It is a challenge when you have a lot of providers. That is tough.
Yeah.
Dr. Botish, do you have any? Oh, good. Noah, you're here there. Excellent. Nothing to report out, I see. Or if you can just put it in your text there, Noah, or in the meeting chat and let us know if you have anything to report out would be great. We'll check in there. Brooke from Cornerstone?
Yes, I'm here. Can you hear me?
We can.
So I don't have much to report out. Things seem to be going really well. We implemented fluoride and oral health posters in all of our patient exam rooms, which has been really beneficial because it starts the conversation with our patients. But otherwise, everything seems to be smooth sailing.
Excellent. Excellent. Sarah, Dr. Adams, I see you on the call there.
Hi, hello, everyone. Yeah, nothing really to report except, just especially when it comes to like the PHQ-9, our office was really good about consistency and in getting those screens done. But in the past, prior to this QI, didn't really do any suicidal screening unless there appeared to be a risk factor on the PHQ-9, and just feels really good to be consistently doing it and feeling more confident in talking about hard stuff. And it's amazing to me how, they fill out the PHQ-9, but then when you get a chance to really talk to them, you get a lot more information. And so I'm really seeing the value in doing both at every well visit we do it for 12 and up.
That's great. That's great. I would echo that from my experience too, Sarah. That just practically, there is a benefit, I think. Dr. Inez Cuevas?
Hi, can you hear me?
We can.
Hi, how are you? Good.
Good. Thank you for being here.
Yeah, so regarding my clinic, I think that volume-wise is not a problem. I think that we have a good show rate, so I can do my screening on the social determinants since I work with underserved population or patients and families. The thing with the oral health, time-wise, I struggle. Sometimes it depends on the volume of patients and to identify the patients that I can do the fluoride. So I try to do my best time-wise, but sometimes it's difficult to get on board the team that works for me, because I used to go to 2 clinics, so 2 clinic settings, and it depends on the clinic that I work. So sometimes I have more time to do the fluoride and do the anticipatory guidance and make everything like to run well. But I think that I have improved in that. So I can say that this experience has helped me to improve my clinic regarding those 2 topics.
Great. You know, and it's interesting. It's kind of a common theme. Noah responded in the chat box too. I don't know if people saw that. A similar kind of struggle of running it when you have this rotating teams coming through. For them, it was apparently, and also like the new residents coming in too, which is obviously, you know, that happens beginning of this month too. So that is always a challenge with these programs. So you guys are not alone. That our little bump down may even be sort of a function of that those changing teams.
Exactly, but I'm happy with the results. So
Good.
I think that I'm doing better. Mm-hmm.
We certainly are impressed by it all. I didn't see Dr. Vargo on. Sue, are you on today? Let's go on to Francis, Dr. Comer.
Hi, yeah. I think I feel like we're kind of maybe starting to make progress in, like everyone says, when you're working with a lot of residents and other people in your office, getting everyone on board, but creating dot phrases and re-emphasizing the use of like the full, so we do the depression and the developmental screens, and having the dot phrases that include the scoring has been helpful for us in getting more people on board and doing it. It just is because it reminds the residents as they're going through the note to do it. So that has been helpful for us. And I feel like we're starting to see some positive change, but it's a lot of reminding.
It is. It's like, yeah, no question. Alexis at Kettering. And I didn't see Alexis on here, so we'll go to Dr. Bennett. John, I see you're on there.
Yeah. Yep. No, I think everything's going okay as far as I know. You tell me if we missed anything, but we're doing okay. We don't have any residents, so I think we're doing all right.
Good. Any difficulties with reporting or anything?
As far as I know, not. But
okay.
But let me know if
good.
If anything's missing.
Good.
Yeah.
Good. Yeah. Well, good round of report outs, guys. I think some very themes sort of emerged there in our discussion. So with that, I'll turn this back over to Elizabeth, and she'll kind of go over our last kind of things, and we'll get you guys back to your day a little early today.
Absolutely. Thanks, Dr. Bowling. As we said at the beginning of the call, data is due next and last round, August 18th. If you have not submitted your data, we understand there's barriers and limitations. If you could try to get that to Haley as soon as we can, so that we can start to kind of put all the results together. Your post-survey evaluation and PDSA cycles will be due September 21st. Our next action period call is, I believe, August 24th, and it is on depression screening. Dr. Sarah Denny will be providing the education for that. And then the following month in September will be a sustainability and, you know, doing the work beyond the guardrails of this project. So as we said at the beginning of the call, if there are any questions or anything that you need from us, please reach out. We're always happy to help you in any way that we can, and wishing you the best of the rest of your week.
Thanks, everybody.
Thank you.
Thank you.
Thank you.
Thank you.